All right, it's 1:30, so I think we'll get started here. Thank you all for attending on this lovely afternoon. We have four about 10 to 15-minute talks. Ideally, we're going to have time for around 10 minutes or so at the end for a panel discussion for you to ask questions. We have three outstanding speakers, really experts in the airway for the obstetric patient. I think what we'll do is we'll introduce everyone first, just to kind of keep the flow of these talks going. So it's really an honor to introduce first Dr. Joy Hawkins. She's from the University of Colorado, where she's a professor of anesthesiology. She has completed both fellowships in critical care at UT Houston and obstetric anesthesia at Baylor. She's a former SOAP president. She's received their Distinguished Service Award, given the Fred Hare Lecture. Extremely active in the ASA. She's been chair of the Committee on Obstetric Anesthesia for 5 years in the past, and is also chair of the task force that wrote the practice guidelines for obstetric anesthesia 3 times, 98, 2007, and 2016. Currently, she is the ASA section chair for publications. She is going to be talking about conversion of failed neuroaxial anesthesia and going to general, knowing when and avoiding the pitfalls. Next, a great privilege to introduce Dr. Barbara Orlando. She is currently associate professor in the Department of Anesthesiology at UT Health, part of the McGovern Medical School. There she serves as the director of OB anesthesia. She had previously been at Mount Sinai West, where she was the director of OB anesthesia research. She completed her training, actually 2 anesthesiology residencies, one in Paris, France, and the second one in the US at the Montefiore Medical Center in New York. She has her master's degree in biology and pharmacology, and she is going to be speaking on high-flow nasal cannula in obstetrics. What is the evidence? And finally, I'd like to introduce Dr. Naveed Siddiqui. He is coming from Mount Sinai Hospital. He is an associate professor at the University of Toronto, a clinician scientist where he serves as director of the perioperative anesthesia research unit. His academic work focuses on airway management, regional anesthesia, and obstetric anesthesia. He has a strong emphasis on the use of ultrasound in these techniques. He's led several randomized controlled trials, multidisciplinary research initiatives looking at patient safety, optimizing perioperative outcomes, and advancing point-of-care ultrasound. He has great knowledge in airway management and is a board member of the Society of Airway Management, where he contributes to national guidelines. So with that, I will begin. Unfortunately, Dr. Sonia Viday, who is going to give this lecture, isn't available, and so I'm filling in for her. And so we're going to just start with sort of lessons learned and recent updates to the obstetric airway algorithm. So, as I'm sure you're all aware, about 3 years ago in 2002, the ASA went back and revised its airway algorithm. The previous version had been in 2012. They did a systematic review of the literature, looked at over 12,000 articles, had input from multiple expert consultants, both within and outside of anesthesia. And they stressed a few things with these new guidelines that came out 3 years ago. I have them listed there, but really the importance of planning ahead, as we all know. Optimizing the oxygenation, not just the pre-oxygenation, but oxygenation throughout the intubation process, throughout failed intubation, and so on, really focusing on oxygenation. Talking about potentially using video laryngoscopy early on, talking about the benefits of second generation supraglottic airways being better than the first generation, calling for help early, being aware on the passage of time, and really limiting those attempts. having part of the algorithm to awaken the patient earlier on in the failed airway attempts, and then also highlighting invasive front of neck airway access. So I think, with this lineup of speakers, we're really hitting optimizing oxygenation, supraglottic airways, front of neck access, and Dr. Hawkins is going to be talking about when should you do general and avoiding some of the pitfalls. In the next slide here, have laid out the 2012 algorithm versus the 2022, and you can kind of see right there in the red circles sort of the things we just talked about. And these are the new sort of areas in the algorithm, and again, this is outside of OB, this is all airway, but really optimizing that oxygenation, limiting those attempts, right? And supraglottic airways, front of neck access, and so on. Now, obviously you're here because of the obstetric airway, and so we're going to move now sort of out of that general ASA airway algorithm to talk more specifically about the airway in pregnancy. There is no ASA OB anesthesia airway algorithm, at least not yet. Hopefully there will be developed in the next year or so. So we do have a significant development in 2015 with the Obstetric Anesthetists Association, the OAA, and the Difficult Airway Society produced these joint guidelines about 10 years ago, focused really on the obstetric patient. And you can see there's a lot of similarities to the new version of the 2022 ASA airway algorithm that applies overall. You have that early airway planning, algorithms for acute management of failed intubation, and then finally a third algorithm for can't intubate, can't ventilate, can't oxygenate scenario. So what I'm going to go through is some of the lessons we've learned and things you need to specifically think about within OB. First thing is, how frequent is this, right? How frequently do we have a difficult airway on OB? And I've put out a variety of studies that have been in the literature. On the left-hand side, you can see the rates, and it's nice to know that over the past 15 years, we've kind of decreased from approximately 1 in 154 to somewhere between 1 in 500 to 1 in 800, where we get into the can't intubate. I put the definitions there because it's slightly different between the studies. I'm going to sort of highlight the last two, and I know Dr. Hawkins will probably touch on those in her slides also. But on the second to the last one, that 2014 study, that's part of the SCORE project. It was a 5-year study period looking at 5,000 cases of general anesthesia for cesarean delivery. And it involved about, I think, 30 institutions, and that's where that rate of about 1 in 500 came out. Now, we had a little over 5,000 patients, so that meant they had 10 airways that they were unable to intubate. And the good news out of that study was in all 10 of those, they were able to place supraglottic airways and ventilate the patient. And so they didn't have any can't ventilate scenarios. Okay. And then we go forward to the 2022 study. This is a multi-center retrospective cohort study of general anesthesia for cesarean delivery. It's 45 medical centers and 15,000 cases of general anesthesia for cesarean delivery. We have a failed intubation rate of about 1 in 800. And also from that study, not only did they give the rates for can't intubate, but they also went ahead and talked about difficult intubation, right? So along the left, that's how they define difficult intubation, poor view, multiple attempts, needing to rescue, so on. That rate is a lot higher, right? It's about 2%. Now, there are predictive factors that I have shown on the slide where you can see age and BMI and Mallampati score, and almost all of them have nothing to do with OB, even though this was an OB anesthesia study. But what we can see is the more predictive factors there are, the more likely the frequency that you'll have difficulty intubating. So those are the things you need to think about if you're going to be involved, in that obstetric airway. Again, what are the recommendations? Kind of combining them from the OAA and the ASA updated algorithm, right? Getting that early airway risk assessment, trying to see those patients ahead of time so you can formulate a plan. And then in preparing for it, ensuring you have appropriate equipment, minimizing distractions, optimizing positioning, talking about oxygenation. Again, not only pre-oxygenation, but oxygenation throughout, and then having appropriate monitors on. Now, the speakers that follow me, like I said, are going to touch on a variety of areas. One area I wanted to bring to light little bit was video laryngoscopy. So just a quick show of hands, how many people have video laryngoscopes, laryngoscopy available in all their OB anesthesia operating rooms? Okay. So I will say that's probably about 75%, which is great. Each time I have one of these airway lectures or attend them, it seems to keep going up. So that's outstanding. And the evidence really shows that video laryngoscopy is associated with a better view, higher frequency of success, decreased number of attempts. Right? But now let's say we do get into that scenario, right, where you're having difficulty intubating. Again, the ASA's focus is really on ventilation. And obviously, if you can adequately ventilate, there's lots of options that you can do on the left. And then if you can't, you go down this emergency pathway. I'm going to show you the OAA's algorithm, which is very similar. And again, early on calling for help, you have that sort of second generation supraglottic airway device and trying that versus mass ventilation. If you get into problems and you can't adequately ventilate, we go down the emergency pathway I'll show in a minute. But if you can, then the big decision is, are we proceeding or are we not, right? And in a couple slides, I'll show you some of the thoughts you should have regarding that. In addition, anytime you get into a difficult airway with a failed intubation, even if you're able to successfully rescue with an LMA or easily mass ventilate and proceed with the cesarean delivery, I think it's really critical that you let the neonatologist know what has happened, because having a failed intubation is a very high risk factor for that neonate needing additional support and needing to go to the NICU, okay? So in some ways much higher than relatively early gestational ages. So in the back of your mind, when you get into those situations, make sure the NICU is aware. Often they are, because they're in there while it's going on, but sometimes they don't think about how it affects the neonate. Okay? And then here we are on that sort of emergency, the third algorithm where you can't intubate and you can't oxygenate. Dr. Siddiqui is going to talk about the front of neck access. And you can see it's kind of a short algorithm there, but it just comes down to, is oxygenation restored following the front of neck access? If yes, then you're getting into this decision of what you want to do if you want to proceed. But if you don't, obviously you're going to be going into ACLS quite rapidly and needed to think about doing relatively quick perimordium cesarean delivery. This is sort of the thoughts that the OAA has regarding making those decisions once you're able to oxygenate the mother. Should you proceed? Should you wake the patient up, right? And you can kind of see there really on the bottom in orange, right? What's the ventilation like? Is it difficult? Are you using a face mask? Are you using an LMA? Is it more easy with the LMA to help you decide whether to wake up or proceed? Are there problems with the airway? And all these things sort of enter into your decision process. So it's not really a black and white scenario, but it's something that comes up almost every time in these difficult airways is, now we can oxygenate, what should we do, right? Should we proceed? Should we not? Okay. If you decide to proceed, or I should say, regardless of what you decide, there's things you need to think about, right? So if you wake the patient up, we have those in green on the left, right? Oxygenation, ventilation, and after waking, to then review the urgency of the surgery. How is the fetus doing? Make a decision whether you're going to do regional or are you going to try to secure the airway awake. If instead you're unable to intubate, but you are going to proceed with the surgery, what are you going to do for maintenance anesthesia and ventilation? Is it going to be controlled ventilation or spontaneous ventilation? Thinking about minimizing aspiration risks. encouraging the obstetricians to operate as quickly as possible to minimize the time that you're in this scenario. And then I think the last piece here before we move on to the speakers is equally important to everything we've gone through is really the extubation. And a lot of times, unfortunately, that scenario gets ignored. So you've had a difficult airway, you've gotten the patient through it, you were able to place the endotracheal tube, and now the case is done, and here comes the extubation. Probably as important or even more important than the part you've just been through. So having a strategy, appropriate individuals present, where are you doing it, how feasible would it be to place a supraglottic airway if needed, are you going to keep them oxygenated as they're coming out and you pull that endotracheal tube out? And the reason I think this is so important is a study that's almost 20 years old now from Dr. Meyer. This is data out of Michigan looking at maternal deaths. They had about 15 deaths that were anesthesia related or anesthesia contributing that they looked at. None of these deaths were during the induction of anesthesia. They were all at the end. Right? 5 were from hypoventilation and obstruction during emergence and recovery, and then others were from lapses in postoperative monitoring and inadequate supervision by the anesthesiologist, right? So again, we have all these algorithms and so on that kind of get you through these scenarios of can't intubate, can't ventilate, can I oxygenate? But again, when it's time to remove the endotracheal tube on these difficult airways, extremely important that you're around and have plans to maintain oxygenation. So with that, I'm going to hand off to Dr. Hawkins for the next presentation, and we'll take questions at the end.
All right, thank you, Mark. So think about this. I know everybody in this room has been in this situation, and it is just one of the most frustrating things that happens to us on labor and delivery, isn't it? So you thought that epidural from labor was working great. So when they call the C-section, you dose it up appropriately, you get in the room, the belly's scrubbed, the drapes are up, and the Alice test is positive, and she's ouch, ouch, ouching the whole time, or even worse, they make skin incision, get down to fascia, and all of a sudden it's ouch, ouch, ouch. So that's what we're talking about here, is that horrible situation and how we should handle it from here. So how often does that actually happen? Sorry, we don't get to know because I got to find the controls here. All right, here we go. So is this really an issue? So we have some numbers we can kind of hang our hat on. This is a meta-analysis that looked at a pooled incidence of how often it was found that patients had intra-op pain during neuraxial, during a C-section, 17% overall. That means almost 1 in 5 of our patients having a C-section report some amount of pain. And if you look at how that breaks down, spinal CSEs do a little better, but epidural top-ups for C-section, the kind of situation we're talking about here, 33%, 1 in 3 of our patients are having pain. That's really just incredible when you think about it. Take yourself to the OR, you're doing a total knee or a total hip, and you have a spinal, and they do their little Alice clamp, and she says, ouch, and boom, the LMA's in, and off we go to sleep. We don't even think twice about it. This, I don't think we've really realized in the past how common this was happening to us. Now, in the UK, they too do almost all of their C-sections under neuraxial. This is from the National Health Service Litigation Authority, which is kind of equivalent to our ASA closed claims database. So they reviewed 360 cases of pain during cesarean. They found that this complaint was actually the #1 cause for successful malpractice claims. So these were the ones where the patient was found to be true, and the anesthesiologist was found to have been at fault here. So out of these 360 cases, they found some interesting things. 50% of the time, the anesthesiologist had never told the patient as part of the consent that this was a possibility, nor what the plan would be if pain did occur during the case. Second, no documentations. The anesthesiologist had not put down, here's what was happening, here's how I troubleshoot the situation, here's my thinking on how we proceeded from there. 42%, the C-section was allowed to start despite the fact there was an obviously inadequate block, the ouch over the Alice test, and despite the fact there was not adequate intra-op anesthesia that was obvious to everybody in the room, there was either a delay or reluctance or refusal to convert to general anesthesia. And one of their conclusions from this is pain is whatever the person experiencing it says it is. We do that whole pressure pain thing. Who the heck cares? If she thinks she hurts, and we need to make a new plan. By the way, within this article, they give excerpts from the depositions for many of these cases, and it is heartbreaking, just heartbreaking what these women went through. I would highly encourage you to take a look. So, we've been taught over and over again we should avoid general anesthesia if we can in all pregnant patients. So is this safe? Should we be thinking about general anesthesia? So this Cochrane review found that there was no evidence to show that regional anesthesia is superior to general in terms of major maternal or neonatal outcomes. Think about that for a minute. No evidence that regional is superior for major complications. Now, you can see a whole litany of things down here that we think are maybe less important, but still important, complications from general anesthesia. So yes, it's reasonable to try to do neuraxial when we can, but as we will talk about, it is safe to do general anesthesia when we need to. So what about failed or difficult intubation? So Mark alluded to this when he was talking, but this is the same MPOG study where they looked at 15,000 intubations. 1 in 49 were difficult, meaning they eventually got the endotracheal tube in, but had to try some different things to do that. 1 in 808 completely failed. No endotracheal tube ever entered that trachea, but they were able to get an LMA in every one of those. There were no deaths. So I think it's important for us to realize we have tools at hand. We have ways to oxygenate the patient and avoid a serious complication. So, how do we convert? Let's go back to that positive Alice test we now have, and we have decided with the patient, shared decision making, yes, it's probably best if we proceed with general anesthesia. Well, again, hopefully in your consent, you maximally empowered that patient. I want you to tell me if at any point in time you're uncomfortable, we have ways to fix that, and we will do that. If she does report pain, validate it. Yes, I hear you. Let's try some things and see what we can do. Have the obstetrician stop. Almost always they can stop for a few minutes and let you try some different things. What that is, whether it's adding additional epidural chlorprocaine or giving some IV or inhaled medications. If you have nitrous on your anesthesia machine, you can try that. Intra-abdominal local anesthetic can be very if you're already in the abdomen, can help. So you can take chlorprocaine, literally pour it in the belly, slosh it around a little bit, and that will help with peritoneal coverage if that's part of it. But let's assume none of those are successful. This block is truly just not going to be adequate. Then you want to tell the patient, here's what we're going to do, inform the surgeon, we're now going to move on to general anesthesia, reassure the patient you will be safe, your baby will be safe. Continue, again, to let the surgeons know what you're doing so they can pause and then wait for you to tell them when they're allowed to proceed. Obviously, you should have equipment in the operating room. As Mark said, that was great that most people now do keep a video laryngoscope in all of their OB/ORs, but also call for help. You weren't expecting to do this, and so you want to have a colleague around who can grab things for you, help you drop drugs, whatever you need to do in a hurry. So what about partner presence? So one of our complicating factors is we often already have their support person in the room, right? Who's sitting right next to us watching all of this happen, and we have to think about their perceptions and how they're feeling about this too. This was a scoping review that asked both parents and providers, how would you handle this? And most parents, the patient and her support person, preferred to keep the partner in the room, keep them present. On the other hand, most staff are very reluctant to let them stay in the room if we're going to induce general anesthesia and do the case that way. Most of the arguments against having the partner stay are really personal opinion, how we feel about it, or the most arguments in favor of them staying are really true clinical findings. And so obviously the end decision is yours, but I think it's a good thing to think about ahead of time before you get into that position. This was a QI project that narrowed down to 3 things that can be really helpful when you're doing airway management in an obstetric patient. First off, use a video laryngoscope. First pass is much, much higher than with direct laryngoscopy, approaching 100%. Second thing is using low flow nasal oxygen. Barbara's going to talk about high flow, but keeping even just their nasal cannula on, keeping that flow going during the period of time she will be apneic from your muscle relaxant and during laryngoscopy. And that has a very good chance of maintaining her saturations for a longer period of time. And then having her in a little bit of a head up position, 20 to 30 degrees, whether that's the back of the bed up or reverse Trendelenburg or however you like to do that. And obviously if you can do some team training, some simulations with your L&D colleagues, that's great too, so they know how they can help you. All right, I'm not going to tell you how to do general anesthesia. You get it, you know that part. But a few things to think about. Again, start off with the patient head up while you're doing your pre-oxygenation with a tight mask fit. Do your rapid sequence induction and give enough hypnotic, all right? I don't care if you already have some sympathectomy. You can treat hypotension if you need to, but you want to remember that this woman is frightened. She's had no pre-medication, and 1 milligram per kilogram of propofol is not going to do it. So give her a good, adequate dose of hypnotic, followed by your muscle relaxant and cricoid pressure. Think about controlling the hemodynamics. That may mean giving some esmolol if she becomes really tachycardic in the midst of all this unexpected things going on, or using nitroglycerin or labetalol if she becomes hypertensive with your laryngoscopy. Then after intubation, initially you may want to keep your MAC at around 1 to give them some good uterine relaxation to deliver the baby, and then very quickly reduce that to a half MAC to avoid uterine apnea and supplement with nitrous oxide or TIVA or however you like to do these cases. And think about recall. That's an important thing in our OB patients. Plus, if your epidural local didn't work, your epidural morphine might not work either. So what's your plan now for post-op pain? Are you going to do TAP blocks at the end or QL blocks, or are you going to just think about how you want to handle that? So what about awareness? This study showed that awareness may be as high as 101 in 256. So they looked at over 3,000 OB patients interviewed after they'd had a general anesthetic for C-section, and 12 had accidental awareness. Now, it was not reported until somebody flat out asked them, and I think that's really important to remember. Over half were distressed, almost half felt like they were paralyzed and awake, and unfortunately 17% had pain. And most of these occurred either during induction or emergence. So be especially aware as you go to sleep, again, that adequate dose of hypnotic, and then as you're waking up, how you handle that. And it's important on your post-op visit that you directly ask that. So something like, what do you remember from the time you went to sleep until you were waking up in the recovery room? Ask them a very direct but open-ended question and let them tell you. Otherwise, you may not know it's occurring. You want to use that post-op visit again to get patient feedback if you are concerned about how she was feeling about this conversion to general anesthesia was unexpected. Let her partner tell you their perception of how this went. Give your explanation of the event so they feel like they have complete transparency about what went on, why you decided to do the things you did. Document it in the record, what you were thinking about at the time, the actions you took to address it. Refer the patient to an appropriate professional. We are very lucky on my unit. We have a group of 3 psychologists who just deal with peripartum women, those who have complex pregnancies, who have bad outcomes, and then situations like this, because this is an independent variable for the patient developing PTSD. Now, in your practice, I think it's a great idea to audit the general anesthetics that occur and or the regional anesthetics that get a high amount of systemic or additional medications during the case. That really should not be happening very often, if at all. And you want to look for opportunities for changes in practice or educating colleagues, perhaps. So we found, for example, that a lot of our conversions happen nights and weekends. And when we looked back at what might have been done differently with that epidural, other than one that had clearly already failed in labor and should have been replaced, the other thing was inadequate dosing. So people were giving maybe 10 cc's of 2% lidocaine. That is not nearly enough to do a C-section with. So again, there may be opportunities there to help your colleagues bring their practice up to a better standard. So do anesthesiologists impact childbirth-related PTSD? Yes, we do. And two of the things we've just talked about are high on the list of what may lead to that psychological complication. The failed neuraxial that requires rescue medications or conversion to general, and then the accidental awareness. So these are things you want to incorporate into your thinking when you are needing to convert a neuraxial anesthetic to a general. And finally, I just want to close with this quote that I really like. Childbirth persists in women's minds, often vividly for a lifetime. More than that, its significance can affect their sense of self, their relationships with their children, their partners, their future ability to interact with healthcare services, and their own physical and emotional well-being. Positive effects are also deeply felt by many women. Again, how we interact in the moment with them. How a woman feels during birth, and crucially how she is treated, is important for her well-being in the long term. And I think this is one of those situations where we can make this at least an acceptable experience for her, or we can make it something that is far more traumatic. And our trauma-informed care that we're all focusing on these days, this is one of those situations where we can definitely make a big difference. So thank you. Okay, Barbara's next. Ooh, look at us go.
Good afternoon. It's going to be hard to follow after Mark and Joy, but I'm going to try. So I'm going to discuss the role of high-flow nasal cannula in obstetric and the evidence behind it. The disclosure, I'm a consultant for Edwards Life Science. Hopefully by the end of the presentation, we'll be getting a better knowledge of what the persistence of high incidence of failed intubation in obstetric. We'll have an idea of the role of high-flow nasal cannula in the management of obstetric airway and all the advantage of it, and we'll also know the limitation of it. So I'm going to start with some numbers, and some of the studies have been presented before. This one is closed claim studies in obstetric anesthesia. It looks at the most common anesthesia-related cause of maternal death and permanent brain damage in claims in anesthesia, and they are associated with general anesthesia due to difficult laryngoscopy, difficult failed intubation, multiple attempts leading to progressive difficulty with ventilation, substandard anesthesia care in managing difficult intubation, and some human factors, mostly loss of situational awareness. That second study that was published in 2014 is the SOAP score project, where the author looked at 30 institutions, submitted data on 257,000 obstetric anesthetics from 2004 to 2009 in both US and Canada. And they looked at the incidence of serious complication in modern anesthesia practice. And that third study I'm going to present here is on the recent one that was presented earlier, that was published in 2022. It was a review of literature, multi-center perioperative growth data, showing 1 out of 49 incidents for difficult intubation. 88% of those difficult intubation were based on the view. 16% were defined as requiring 3 or more attempts. The conclusion for this last study was a failed intubation incidence of 1 out of 808. It was defined as any attempt without successful ET tube placement, and all 18 were rescued using a supraglottic airway with only 1 arrest, no death. The risk factors that were cited in this article were the Mallampati 3 or 4, a BMI of 40 or more, and maternal age of 35 or more. So how does the high-flow nasal cannula work, and what are the benefits in pregnancy? To go back a little bit to the physiologic change of pregnancy that you all know, we have an increased metabolic rate, higher oxygen consumption, and a reduced functional residual capacity due to the gravid uterus pushing the diaphragm up. So pregnant women are more susceptible to rapid desaturation and hypoxemia, especially in urgent situations when the time for pre-oxygenation is limited. And while a method of 8 breaths over 60 seconds may be sufficient for end-tidal oxygen to be more than 90%, the safe apnea time, which I will define later, achieved in pregnant patients may not be enough for managing a difficult airway. To increase the duration of that safe apnea time, a combination of pre-oxygenation and apneic oxygenation may be more advantageous, so that's where the high-flow nasal cannula might come into play. So this study that was published in 2020 in the European Journal of Anesthesiology is looking at the efficacy of high-flow nasal oxygenation during a rapid sequence induction for general anesthesia with general anesthesia for C-section. It's a prospective randomized control study. And it was looking at a few parameters where the high-flow nasal cannula might be actually beneficial. So one of the first conclusions from this study is that unlike conventional low-flow systems, such as nasal cannula, the high-flow nasal cannula provides a consistent FiO2 that's not diluted by the patient inspiratory flow. The high flow rate helps clear exhaled carbon dioxide from the upper airway, which can reduce the work of breathing. It also can generate a small amount of PEEP, which can help keep the airway open and improve gas exchange. And lastly, the heated and humidified gas is more comfortable for the patient, which can lead to better tolerance and compliance from those patients compared with non-invasive ventilation methods such as CPAP or BiPAP. So if we look at the literature on high-flow nasal cannula in OB patients, there's 2 mostly that I found that were published within the past 5 years and help with a certain number of conclusions. So that first paper published in 2022 looked at the role of high-flow nasal cannula for pre-oxygenation among pregnant patients. It was a current evidence and review of literature. Some of the conclusions are that pre-oxygenation and apneic oxygenation are improved. I'm going to go over the acronym THRIVE later. So it can prolong the safe apnea time, and it can provide a higher PaO2 after intubation compared with standard face mask. Another conclusion was that there was a reduced risk of hypoxemia when it was used during the perioperative period before induction of general anesthesia. The second paper was a randomized clinical trial that was looking at the efficacy of high-flow nasal oxygenation for maintaining maternal oxygenation during RSI in pregnancy. And they found similar conclusion. They also looked at safety for both mom and baby, and they concluded that this was a safe way of taking care of the mom with good APGAR scores, umbilical cord gas, and no impact on fetal heart rate. So let's go back to defining what THRIVE is. That's an acronym for transnasal humidified rapid insufflation ventilatory exchange. It's a device that allows for delivery of high flow oxygen up to 70 liters per minute. It's heated, humidified up to 37 degrees Celsius. It's delivered through nasal cannula using an air oxygen blender. It allows for an FiO2 up to 1, and the use of high flow nasal cannula for apneic oxygenation is called Thrive. The various benefits from this technique over conventional pre-oxygenation, some of them I already mentioned them, but I'm going to go over it again. So you have the heated and humidified oxygen that improves mucociliary clearance, protect airway mucosa, decreases the incidence of mucus plug formation, and reduces the incidence of atelectasis. The high flow matching with the peak inspiratory flow can be provided, and it reduces the work of breathing. It allows for delivery of high and fixed FiO2, which reduces the air entrapment and improve oxygenation, pre-oxygenation. It allows for washout of anatomical dead space, which reduces the rebreathing of CO2. The flow up to 70 liters per minute is surprisingly very well tolerated by the patient. It also because it's heated and humidified, which makes it less painful for the patient to tolerate. Generation of PEEP. And since it's a nasal cannula, you don't need to remove it during laryngoscopy. And there's a smooth transition that can happen from pre-oxygenation to apneic oxygenation. It's way better tolerated than a tight fit mask, especially in patients who are claustrophobic. So as I said, again, better compliance. A lot of the literature that we have is from different patient population in emergency situations such as cardiac arrest, critical ill patient. And this review article published in 2021 looked at the high flow nasal cannula for respiratory failure in adult patients. So the author concluded it can help improve oxygenation, reduce the work of breathing, and potentially prevent the need for endotracheal intubation. The patient comfort is way better than any other invasive ventilation method. It's also hand-free, which for us is a really useful parameters. Some of the potential complications that were listed in this paper were gastric distension and a theoretical risk for pneumothorax. However, the literature on OB is a little bit divided. The 4 papers I'm going to present you after show mixed finding of the high flow nasal cannula on OB. This first paper is on perioperative use of high flow nasal oxygen in obstetric patients. It was a systematic review. The author concluded that the advantage of the high flow nasal cannula over conventional methods in low-risk patients may be uncertain, and its benefit in high-risk patients required further investigation. The second paper on high-flow humidified nasal pre-oxygenation in pregnant women was this one, a prospective observational study. Dan and al. Concluded that the pre-oxygenation is inadequate, actually, if you try to reach an end-tidal oxygen of 90%, and it cannot be achieved in 3 minutes. And as you remember in the prior presentation, it's one of the suggested requirements for difficult airway management in general. They anticipated a way longer time requirement to reach an adequate end-tidal oxygen. The 2 other studies, this one from O and Al, concluded that end-tidal oxygen of more than 90% cannot be achieved even after 8 minutes of pre-oxygenation with the high flow nasal cannula. Of course, 3 minutes is an inadequate time for pre-oxygenation, even with a face mask in pregnant patients. That's what they mentioned in this paper. And air entrapment was the main contributing factor for inadequacy. That last one from Sultan and Al was a prospective up-down sequential allocation study looking at effectiveness of vital capacity breath using the high flow nasal oxygenation versus the tight fitting mask. Here again, they concluded to a lack of efficacy even with up to 20 vital capacity breath with the high flow nasal oxygenation. and only 70% of the patients were achieving the target of end-tidal oxygen of 90. Face mask was even found to be more effective at achieving the end-tidal 90 compared with the high-flow nasal oxygen. So in terms of the latest obstetric, latest airway management changes in this paper that we presented earlier from 2022 on guidelines in airway management. Some of the things that were listed in there regarding OB airway management was having a fully equipped difficult airway cart available on labor and delivery unit, optimized pre-oxygenation with either low or high flow nasal cannula for an end-tidal of more than 90% within 3 minutes. So is the high flow nasal cannula better? That was not defined in the paper. Video laryngoscopy available in each OR, OB-OR, using second-generation LMA if you cannot intubate, and suction-directed laryngoscopy to prevent aspiration. So the question that some of the more recent literature is looking at is, should we use the end-tidal oxygen more than 90%, or should we use a different parameter to assess the efficacy of high-flow nasal cannula? The one that's coming out in the papers is the time to desaturation. So the question is that, is it a better target to assess its efficiency on OB? In this paper from 2022, you have 3 papers here. I'm not going to all describe them for the sake of time. But they were all published within the past 5 years. The last one on the slide is from 2025. So the conclusion are that high-flow nasal oxygenation significantly prolongs the safe apnea time, which is the time that you have until the patient starts deciding. Even after achieving an end-tidal of 60%, the safe apnea time was largely prolonged in a non-obese patient. And the apnea time was superior with the hand-flow nasal oxygenation compared with the face mask pre-oxygenation in all models. End-tidal oxygen after intubation was higher in the high-flow nasal oxygenation group compared to face mask ventilation, but it was not applicable for morbidly obese patients with a BMI above 50. And lastly, the pre-oxygenation using the high-flow nasal oxygenation provides a higher arterial PO2 and end-tidal oxygen concentration during general anesthesia with RSI in patients with obesity. And that's that last study from 2025. And the current guidelines for OB patients that were published in 2015 do include the use of either nasal cannula or high-flow nasal cannula for apneic oxygenation during airway instrumentation for pregnant patients. So high-flow nasal cannula likely might have more and more values in the coming year in the perioperative pre-oxygenation. Should we use a goal of end-tidal oxygen above 90 or the time to desaturation to assess the efficacy of it? Can it be used in the obstetric population for management of respiratory depression? It seems like the answer is yes, but it definitely needs more data to assess it in obstetric, especially in OB emergencies.
Okay, great. So that epidural has failed. We are converting into general anesthesia. We don't have time. Time is money. I'm going to run fast with my presentation to save this patient. So no conflict of interest that I have, except that I am mildly addicted to use of ultrasound in my clinical practice and have an unhealthy obsession with the airway algorithms. So that airway is failing. What we need to recognize is what are the challenges of failed airway and how can we manage these obstetric patients. What is the role of supraglottic airway device and how it's used to rescue and in certain planned procedures for obstetric patients, and the use of pre-procedure ultrasonography to make your front of access more reliable and with better outcomes. We know that the obstetric airway is difficult, not just because of the anatomical and physiological changes of pregnancy, but also due to the environmental challenges that we face at the labor and delivery floors, such as like urgent situation, stress, communication lapses, which makes OB airway not just difficult, but highly unpredictable. So since we are in the failed airway scenario, a place where we don't want to be, it is important to define failed airway in obstetrics. The definition includes inability to intubate the trachea after 2 attempts, combined with inadequate oxygenation or ventilation that cannot be maintained using the mask or the supraglottic device. Strikingly, its incidence in obstetric population is 10 times higher, as we saw in the earlier slides, than the general population. So almost every airway society has their own algorithms. For the purpose of this talk, I'm going to focus more on the Obstetric Anesthetist Association from UK or Difficult Airway Society guidelines, as well as the journal ASA algorithm. And I'm going to dive directly into where we have failed to intubate. Now we have to maintain oxygenation. So how do we maintain oxygenation? We can use the supraglottic airway device. Both the algorithms recommend it. Many different kinds and shapes are available in the market for LMAs. I will broadly focus more on the second generation LMA, such as the iGels. So when to use LMAs, as we saw in the previous algorithm, when our intubation fails, LMA can be used to guide us for the intubation, to oxygenate the patient, and in certain smaller cases, such as manual removal of placenta, it can be used as a primary mode of your airway management. Why are LMAs effective? The second generations are especially effective because they have the high seal pressure and they have the integrated gastric channel through which we can allow gastric decompression. They also provide rapid oxygenation and ventilation, and it's faster to insert the endotracheal tube in a critically hypoxic patient. They can also provide a bridge towards our definitive airway, which is either front of neck access, or you can do a bronchoscopy through it to intubate. With any other devices, there are limitations of LMA. They are not a definitive airway. High risk of aspiration candidates, such as class 3 obesity patients, would not be a good candidate for LMA insertion. When you have done multiple attempts, and you know that you have done multiple attempts of intubation, and your airway mucosa is fragile, don't try to insert LMAs at that point. There is limited utility in emergencies requiring prolonged ventilation. So if the case is, it might be a placenta disorder that you expect that this patient is going to be in the OR for a longer time, LMAs are not for this situation. And they may delay progression to front of neck access if we are trying to struggle with that LMA at that time. So now all oxygenation has failed, and we are in the algorithm 3 of the difficult airway algorithms or obstetrics. So at this point, there is no other way except to perform the front of neck access. And almost all airway societies recommend EFONA at the time of cannot intubate, cannot oxygenate. So how do we do the front of neck access? What are the traditional landmarks? How do we locate the cricothyroid membrane, which is our main target? In healthy subjects, it's pretty easy to find the thyroid cartilage. Below it is the cricothyroid membrane. However, it's not that easy. When studies have been done on this subject, trauma surgeons and anesthesiologists were asked to palpate the cricothyroid membrane in the center of it, And unfortunately, we failed miserably, both the surgeons and the anesthesiologist. Similar studies have been done in pregnant patients. One done from our institute a few years ago show that only 39% of us are accurate in identifying the middle of the cricothyroid membrane. And one of the predictors for difficulty in identifying the cricothyroid membrane is your increased neck circumference. So ultrasonography is now making its way into different anesthesia procedures. Multiple studies have been done which suggest that ultrasonography is much more superior to identify the cricothyroid membrane compared to your traditional landmark. But would you do ultrasonography when you are in that situation? No. And would it translate into better outcomes? So for that, because cannot intubate, cannot oxygenate is a very rare scenario. It doesn't happen every day. To do a proper study on this is not possible. So we did published a study on cadavers that came up with a good editorial. In this study, we randomized our trainees to ultrasound or palpation group, and we actually gave them scenarios where they had to perform the front of neck access. So when they used ultrasound, the success rate improved to 5.6, and the relative risk reduction of complication was 2.9. Again, when to use ultrasound, I'm not advocating to go and find ultrasound when you are in that situation. You have to understand that this has to be done earlier in your planning for a failed intubation. So mark your cricothyroid membrane before your epidural fails or before you are in that situation. There is a good systematic review published in Canadian Journal which shows great images. And for the interest of time, I'm not going to go into the details of the technique, but briefly, a linear probe is used to identify the cricothyroid membrane. You scan the trachea from the suprasternal notch, you go up, you identify the cricoid cartilage. By looking at the string of pearls, here you identify the trachea, you go up, you see the cricoid cartilage, and then you go further, you see the thyroid cartilage, and area in between is your cricothyroid membrane. You can also quickly identify this in a transverse orientation ultrasonography, where you start from the thyroid cartilage, which appears as an inverted V, and you come down and you see the tissue and air interfaces to identify the cricothyroid membrane. Now, coming into the front of neck access, what are the different equipments that are available and techniques? There are many different ways of puncturing the cricothyroid membrane. There are small bore cannulas that are available in the market, large bore cannulas. Scalpel bougie technique is also one of the recommended techniques. So what is the evidence around it? For cannula technique, transtracheal jet ventilation has to be used. High pressures have to be used. You always allow passive exhalation when you're using the small cannula. But it does come with certain complications. So high incidence of barotrauma and other complications related to transtracheal jet ventilation. The second technique is the scalpel bougie technique. The scalpel bougie technique is relatively simpler to do. You again identify the cricothyroid membrane. You use your scalpel to make a horizontal incision. Then you turn the blade into 90 degrees. You put your finger in, and then you put the bougie and reload the tube over the bougie here. So the question is, what is readily available for EFONA at your institute? You should be very well prepared to in simulation drills or other exercises in order to use that equipment. Generally, the literature around EFONA supports the use of surgical techniques. So this is from NAP4 study, where 58 cases of cannot intubate, cannot oxygenate scenarios were identified, in which the cricothyrotomy was done by surgeons in 33 cases, all 100% success. When anesthesiologists managed the cases, the they use narrow bore cannula, which has the lowest success rate. And with the scalpel bougie technique, the success rate improved a little bit. Similar results from the Danish retrospective database studies that suggest that a bigger incision and a surgical technique is better than the cannula technique. Also, like from recent Airway app that internationally captured emergency front of neck registries. And here we see the similar thing, that scalpel bougie technique is more favorable than other techniques of FONA. So all societies except ASA recommend the use of scalpel bougie technique. I understand ASA has to cater for a bigger audience, and that's why whatever is available is recommended by ASA. Multiple options available. Which one to use it depends on your institutional practice. At our institute, we have one clear package for scalpel bougie technique. We train and do a lot of simulation for our trainees to like when they are in this situation, they can improve their procedures with better outcomes. So during during crisis, just keep it simple, train and prepare for one technique. And in summary, it's important to have like training for this rare procedure. Use the ultrasound to pre-mark cricothyroid membrane, especially with high patients who are on the obese side. Ready to use the package, have only one package available, and cannot intubate, cannot oxygenate scenario. You have to perform eFONA. Don't wait for the surgeon. Go with the scalpel bougie tube and save the life. Hopefully, thank you very much for your attention.
We're obviously at the end of time, but if for those of you who want to stay around, we'll answer a few questions here as a panel. If anyone has a question, please come up to the microphone. Or not. All right.
That was it, perfect.
Oh, and then we were perfect on
There is a
time. So,
question.
oh, there is a question.
There is a
Sorry.
question.
I have a question. Do you incorporate the ultrasound and the marking systematically on all your patients?
Not all.
Can you repeat the question? Sir?
Yeah, the question is, do you use pre-marking of cricothyroid membrane for all patients in labor and delivery?
Yeah.
No, but those who have the predictors of difficult intubation and higher neck circumference, those are
so
the
you
ones.
do it systematically?
We do it, yeah.
Very nice.
Christian Sola from Mount Sinai, Toronto, work together with Navid. You need to train to do the ultrasound, but once you train, you need to keep practicing. Every time we do an awake fiber optic intubation in the main OR, we always mark, which is, we call it a double setup. We're expecting to succeed, but if it's not, we already have mark. And only, as Navid said, in difficult patients that we go into the OR, we try to mark before in OB.
Thank you. Any other questions? All right. Well, thank you for your attention.